to do is you want to ask yourself, is the right as brisk as the left? For the patellar, you take your finger and you put it on the patella, and right where it dips down is right where you hit the knee, and it's just a little bit lateral. And so that's a L4 reflex. I chose the right one. For the Achilles, what you do is you have a person be very relaxed. Do not let them dorsiflect their foot for you. You passively cock it up, and then you strike the Achilles tendon like that, and then like this over here. And so he's also very nice and brisk. Now, if I was tapping on Bryce and I didn't think I could get his reflex at all, and I'm debating about calling it a 0, I don't know if he's a 0 or a 1 unless I have him do a reinforcing maneuver. So let's say I'm tapping on him and I just can't get it. So I'm going to ask him to take this finger and draw squares in the air for me. And then if I can get it with the reinforcing maneuver, then it's a 1. If, however, even with the reinforcing maneuver, I can't get the reflex whatsoever, then he truly is a 0. So if you're going to mark someone or grade someone as a 1 or a 0, you better have done a reinforcing maneuver. Okay? By that same token, if you think that a person is brisk, too brisk, I tap their knee, and the other leg goes in, for example, or his arm also gives a reflex. And I'm thinking about calling him a 3 versus a 4. The only way that I can make that clinical distinction is to look for clonus. And so part of the deep tenor reflex test would not only be to do reinforcing maneuvers to differentiate a 0 from a 1, but it also would be to perform testing for clonus. And so in the upper extremities, if he's really brisk, I'll take his hands, relax like this, and cock it back like this, and over here. And if he doesn't have clonus, then he might be a 3 if he was too brisk and he spread. In the lower extremities, I would check to see if he's a 3 versus a 4 by taking his foot and quickly pulling your foot up like that. And so more than 5 beats is, just relax all the way, more than 5 beats is considered abnormal. That's okay. So that's deep tenor reflexes, and you technically do not need to check for Davinsky sign. But even though a lot of people think about that as a part of the reflex testing, that's not what you're graded upon. Just like in the motor examination, I could also ask you to rate reflexes. And so if you are going to be rating someone as a 3 or a 4, you better have done a reinforcing maneuver. If you're going to rate them as a 0 or a 1, you better have, excuse me, I said that wrong. If you're going to rate someone as a 0 or a 1, you better have done a reinforcing maneuver. If you're going to rate someone as a 3 versus a 4, you better have checked for clonus to make sure that you can truly differentiate between those two. Does that make sense? Okay. So deep tenor reflexes are quite easy, just as a motor examination. And so you can imagine that you could do deep tenor reflexes so fast, on someone left to right always. And you can also, at the same time, check for clonus. And you can do deep tenor reflex testing literally in a matter of a minute, and you're going to be done with your test. And then however long it takes you theoretically to grade them. And you need to remember that deep tenor reflex testing is on a 4-point scale.
To be the 3 out of 4 or hyperreflexic, does the spread have to be on the opposite side, or can it be all on the same side?
Spread would look like this. Now remember, I'm testing you guys on your ability to perform the test correctly. I'm testing you guys on your ability to remember the rating scale. And so the rating scale, if I was tapping his reflexes, you might say, oh, that's a 2. You write 2 over 4, 1 over 4, 3 over 4, 4 over 4, 0 over 4. For muscle strength testing, it's over 5. So if you think he's normal, you put 5 over 5. That's how someone can tell that your number is a reflex versus a motor rating strength number, okay? Grading. But your question was?
Spread versus
spread,
same side or opposite side.
So if I was looking for spread, Bryce, what I would do is I would tap his biceps brachii reflex, and I'd watch, for example, this arm. And I would look to see whether or not the impulse comes up to his cord, hops over, and maybe makes his other biceps flex. or whether his pec gets activated and whether he internally rotates his arm. I could also, however, check to see whether he spreads in the same extremity by looking at his fingers, and if his fingers do this each time I tap him here, then maybe that reflex is hopping down his cord. And so spread can either be going up or down ipsilaterally or crossing contralaterally. In the lower extremity, spread is usually seen by, you tap the reflex here, and you look to see if the impulse, for example, jumps across the cord, and for example, maybe activates the same muscles or adducts or something like that. That's more of the finesse of the interpretation. That's really what you'll be expected to know next year when you do your clinical neurology rotation. What I really want you to be able to do is perform the reflex testing correctly, and then to remember on a 4-point scale, that is how you would rate a deep tendon reflex, and on a 5-point scale, that is how you would rate muscle strength. Okay.
Do we have those like?
And you will not use a stick figure. Rather, again, just like with deep tendon reflexes, I will provide for you a graph if I ask you to do something like that. The same type of a graph that you've seen in your handouts for your physical examination practice skills during the FRAD integrated cases. Yes?
So would you rate Bryce as a 3 or a 4?
I've never seen spread in him. He's very brisk, I will say that. But you know, I don't think he is, because when I touch him here on his left, I don't think that he really spreads. He's very brisk, though, for a guy. I would certainly say that. I say that because women are more brisk than men. You know what I'm saying? But you know what? He doesn't have clonus, and he technically doesn't spread. I mean, he doesn't spread to fingertip flexors. He doesn't spread across his cord to his pec or his other biceps or brachioradialis. So I would have to say I think he's a 2. He's just very brisk. Right?
So in a normal clinic, would you note that he's brisk, or does it matter?
It doesn't matter to me necessarily. I would just put 2/4. But some people would perhaps do that. I look for objective findings, because maybe you had a lot of coffee today or something like that, or you're always kind of brisk like that. Yeah, so people just start, and that's not necessarily bad. So that would be how to check for deep tendon reflexes. The third thing that we ask you guys to remember is how to check cranial nerves. And so for cranial nerve examination, you need to be able to remember the cranial nerves. No one's going to have them listed out for you. That means, therefore, that you need to remember that you don't test the first cranial nerve, which is olfaction. Someday you might need to, but that's not part of the screening neurologic examination. So that brings you to cranial nerve 2, or oculomotor. So when you are checking oculomotor, there's 4 things that you're going to look at. The first thing that you're going to do is get your fundoscope off the wall, and you're going to dim the lights, and you're going to ask the patient to look straight ahead at something on the wall. Bryce, I want you to look at this, and I'm going to step right in front of your field of vision. I want you to pretend like you could look right through me as I take a look in the back of your eye. Then what I'm going to do is I'm going to hold my fundoscope in my right or my left eye, for example, as I look at Bryce's left eye. So that way my nose doesn't hit his, and I'll do that. What I usually do is I start far back. I use usually a larger aperture, or sorry, a larger field of light.
Jordan, would you like?
Yes, I will. That'd be great. And so when you look at your field of light, this is really dim. So I usually would choose a larger one like that. Remember that it needs to be white. If you use a green one, that's looking for the nerve fiber layer, and that's really not assessing the right thing. And so what you're going to do is have him look straight ahead. Pretend like you could look right through me. I'm going to start on 0. I'm going to look in his eye like this. I see the red reflex. I'm going to go in. It's easy, and I don't even need to dial up. And he's so easy to see, and I've seen 1. Look over there. Second one. Extremely easy to see, and I've seen him. Don't slow yourself down on the examination. People have told you before, this is not a matter of whether you see the back of the eye. It's doing it right, okay? So just do it and move on, okay? So that's the first part, is looking at the optic nerve. The second part is checking the pupillary light reflex. So look into my eye right here. I'm going to shine it in the right as I look in the right. I'll shine it in the left as I look in the right. I'll shine it in the right and look in the left. I'll shine it in the left and look in the right. To make sure that each pupil appropriately constricts when light is shined directly in it, as well as when light is shined consensually. So that's that. The third part of the examination that you'll do for a second nerve is you're going to check visual peripheral field. So look into my eye right here. I take my thumb, I put it on their forehead, and I have them look directly in my eye. Can you see my whole face? Is any part of my face missing? How many fingers? You must check all 4 quadrants in each eye. Look in this eye. Can you see my whole face if you look in my eye?
Yes.
Is any part of it missing?
No.
How many fingers?
2, 1.
Good, and that's it. And I always do 1 or 2. I don't care what you do, but that's the easiest and the fastest to do. So make sure you check 4 quadrants, 1 eye, and then you're done. The last part of the examination that you want to do is, now that you've checked peripheral fields, now you need to check macular vision. And that's when then you will have a Snellen card or a Jaeger or a Rosenbaum card. It doesn't really matter which card I have there. But what you're going to do is you're going to give the card to the patient, and you're going to ask them, are you wearing contacts? It doesn't really matter if they are or not. That's just how you would ordinarily document it, as if you're checking it with correction or not. And then you say, take your left hand and cover your left eye. Good. Take this card here, hold it, and I'll read the bottommost line that you can read.
I see you. ABCD.
Not sure what to think of that. And then you have the switch to the other eye, and then you use both eyes, okay? And so what you want to do is remember to check one eye, the other eye, both eyes, and then you would document that. So that's checking cranial nerve 2. 3, 4, and 6 often go together. We've already checked the pupillary light reflex. So now what you want to do is look at extraocular eye movements. So sometimes what I'll do is I'll take a pen, for example, or my deep tendon reflex hammer. I'll have the patient look straight ahead. I'll have them look directly at the tip of it, and keep your eyes directly on it and follow it, but don't move your head. And so you perform an H maneuver, so it's up, to the side, down, 3 fields or 3 cardinal gazes, up, side, down. Then you've got to go all the way in to make sure they don't have a near light dissociation of, like, syphilis, for example. And so that's how you check 3, 4, and 6. As you look at him, you're going to look to make sure he doesn't have ptosis also, because that would be a component of the 3rd nerve. Go to 5 now, because we've done cranial nerves 2, 3, 4, and 6, and I go to cranial nerve 5, which is trigeminal. It's largely sensory, but remember that there is motor to it. So have the patient bite down as hard as you can, and you palpate their temporalis and their masseter muscle, and then relax. Okay, so I've checked 5 motor, and now let's check 5 sensory. When I touch you on the right and the left side of your face, does it feel equal or symmetric? Good. So that's all you need to do for the 5th cranial nerve. But you need to check V1, V2, and V3. Do not check the angle of the jaw, because that is not V3. So then you go to the 7th cranial nerve, and remember, for the 7th cranial nerve, while there are a lot of different things that it does, including dampening loud sound through the stapedius and taste on the tongue, we really don't screen with those things. We really check for muscles of facial expression. So I usually mimic what I want the patient to do. Look up to the ceiling as high as you can. Good. Look at me. Close your eyes as hard as you can. Open them as wide as you can. Show me your teeth. Pucker. Put air in your cheeks. Very good. And that's probably all you need to do for the 7th cranial nerve. For the 8th nerve, you could technically do Weber and Renner, but that's really more than you would need to do for screening. So usually for the 8th nerve, I'll have a patient close your eyes, and I'm going to take my fingers and rustle them on the right, the left, or both. Tell me with your eyes closed, what side of my fingers are rustling?
Right, left.
Good. So that's 8th nerve. Very easy. Cranial nerves 9 and 10. For 9 and 10, you usually think of them somewhat together. You can ask the patient to